Welcome everybody to the Surgery and Therapy Summit YouTube page. And today we are interviewing Bob Phillips, who is one of the presenters at the summit. Welcome, Bob.
Hey, how's it going?
Yeah, we are really excited to get to know all about you and of course to have you teach us one of your passions, Splint.
Oh, absolutely. I'm excited to be asked to do this. I love sharing. I love learning from others. So it's always been a blessing to be able to kind of try to get back to the profession in a way that I can.
Yeah, absolutely. I hear you. So, Bob, tell us a little bit about yourself, where you're living and working, as well as what your journey has been to bring you to this point in your career.
Okay, so I'm from a small town in South Georgia, and really honestly didn't know about college at that point. Kind of stumbled into it. I had ended up going to college, had a shoulder surgery, tore the TheraBand that I needed. So I ended up going to a clinic, and turns out they have a lot of students there. And I was there just to get the band, and they asked me if I was supposed to be there to volunteer. So I just stayed. So that's how I kind of got in the door, and I found therapy that way, and thought I wanted to go down the road of physical therapy. And then I noticed the hand therapist in the corner, and she's fabricating all kinds of orthoses, just being really creative, wound care, just all these like just intricate and intimate type treatments. And it drew me in. And so that's how I found occupational therapy. And it turns out that I ended up going to the Medical College of Georgia, which is now Augusta University. And I went back and actually got hired by that same company. And that's who I work for in Savannah, Georgia now. So I've been there, actually this week is 11 years with the same group. So it's been great. I live outside of Savannah, work in Savannah. I'm from the country, so I like to be a little slower paced than, I guess we'll say, the city. But that's where I'm at now. And I've loved every minute of it.
Oh, that's a lovely story. You were destined. You know, sometimes the bad things that happen to us end up being, changing our lives path, which is exactly what happened to you.
That's it was, and I just never heard of it. I grew up, I didn't really know I never thought that far ahead. And yeah, the surgery, it ended up putting me kind of in the right spot. So it's actually funny. My CI at the time, he's actually now the rehab director over all of our companies. So we always joke about it.
Yes. I love that they just pulled you in and got you to volunteer. You were obviously a natural.
Well, I don't know if they pulled me in. I think they thought I was supposed to be there, and I didn't tell them otherwise. I just stayed. And I just kept going back, and it just kind of stuck.
I love it. I love it. Okay. And then education, how did you get into that?
So I started taking the IOM courses. Well, actually, you go through all kinds of courses trying to get your CHD and just trying to develop. And I found the IOM courses, Jamie and Ann, and just fell in love with the systematic approach that they use. It changed a lot of the ways that I treat. And I was joking with Ann one day, and I was like, I really want to teach. And I don't know if I was exactly serious the first time I told her, but it ended up kind of sticking. And she reached back out after I got the certification, and I decided I wanted to do it. And then, so I joined with them probably about a year and a half ago. And I'm kind of going along that path and trying to help them as they help me get better. And then the orthosis fabrication was kind of something I started from day one. It was a goal of mine that I want to teach at least one course in my career. So I actually got to do my first course at Baton Rouge Orthopedic Center last year. And it kind of took off from there. Instagram and everything. I got a couple opportunities here and there, and then a few more, and then a few more, and it just kind of snowballed. It kind of happened fast. I didn't really plan on it being that way. I reached my goal of one, and now I'm just kind of going with the flow, just trying to make a difference.
Yes, well, you also, I find that if you are an educator, it helps you to keep up to date because you have to keep yourself very organized and reading and learning. So it's an ongoing journey. And the best way to learn is to teach others.
Absolutely. So that was one of the main reasons I wanted to join IOM, because you have to stay current. You have to stay on top of things. And if you can teach it to somebody, obviously, you're able to retain it and understand, but you also want to stay current with best practices and advance the field. So that was one of my main goals in doing it, because I felt like I didn't want to become a therapist that got stagnant in their career. I wanted to keep advancing, and that was a way that I would almost have to be pushed. I couldn't really just sit back. I would have to do it. And so I try to take that approach in the clinic, and of course teaching.
So tell us a little bit about the clinic. What injuries are you treating, or what field of?
Oh, we see a lot of stuff. We see a lot of stuff. So, I mean, it could be anywhere from, simple carpal tunnel to post-traumatic injuries. We see a lot of hand finger fractures, a lot of factory fractures. We have the ports here. We have Gulfstream that makes airplanes. So we see a lot of that type thing, burns, amputations, just all kinds of good stuff. There's a trauma center. So we get to see car accidents, gunshot wounds, just all kinds of crazy stuff. But I love it because it allows me to, one thing outside the box, take this evidence practice, mesh it together to form a treatment plan for those that may not be in the Indiana rehab book, or, you have to mesh all this stuff together. And then as far as fabricating, I like to take it and say, okay, what do I need the patient to do? How can I help them at home? And then I just build it. I just make it. And I try to teach that in the course, that it doesn't always have to be a pattern or something that's been made before. Just be creative and help the patient, abide by the principles that you need to do. And, hopefully that you can make a difference in their lives.
Well, exactly. That was going to be my next question. What is your style of teaching? And I think you've answered that question, because if you can appeal to people in the way that they don't feel that they have to recite a textbook or have a file of patterns, they should be able to take any hand and apply their techniques and their principles to that hand and create something very unique. In fact, every orthosis is unique.
That's exactly right. And we talk about that in every course that I do, because you have the same diagnoses, but they're not the same. And this individual may be high use of his hand, maybe a mechanic or something like that. And this one may be, a 75-year-old gentleman that doesn't do anything. So they all need different things, and you have to take that into account. And that's all part of that systematic approach as well, figuring out the patient exactly what they need. And then you can fabricate to those needs. And, of course, education goes a long ways, but I always like to take into account, you got to listen, you got to understand what they need, and then make it for them, because I've seen many times where the therapist knows best and they make something and then the patient doesn't wear it, or the client doesn't wear it. And so it doesn't do any good. It doesn't do any good.
Absolutely. Well, we all know that patients are very seldom compliant with wearing the splints, and often to their benefit, like we've learned with flexor tendons. If they don't wear them, their outcomes are better very often.
Yeah. So it's, it's the cheaters do well until they don't, right?
Yeah.
So.
Yeah, exactly. So tell us a little bit about what you're going to teach us in the summit.
So a relative motion orthosis is something that, came out a while ago, but I think it was just underutilized and believed to be just for extensor tendons at the time, really zone 4 through 7. And it has just evolved much further than that, and into, chronic and acute boutonnieres, trigger fingers, helping with Dupuytren's, flexor tendon repairs later on for FDP excursion. I use it for all kinds of things and get really good results. And it's not really anything I'm doing except putting them in it. And the patient gets to live life. They get to move. We all talk about moving faster, moving better, but they move in a protected plane, or they get to move in a way that gives them a biomechanical advantage to incorporate different things to improve their motion. So that one is just, I think, very versatile, cheap to make. I mean, it's as long as you know what you're doing, and creating balance, especially if you have like an index finger or the small finger, you got to create the balance or it may not work. The middle digits are pretty simple to do, and there are many designs out there, and I'm not so caught up on necessarily this design or that design. Is really just getting your angles right and making sure that it's doing what you need it to do. So that's one that I really love, and oftentimes find that people are scared of, even though it's a small one to make. So in the course, I teach them the way that I like to do it. And of course, that's not the only way to do it. And I find that most of the time it's just being scared. And so the more they do it, the better. And then the other is a radial nerve palsy. It's a low profile that I like to use. It is just easier for the patient to get in and out of clothes. I love it because it provides like almost instant function that they didn't have when they walked in the door. And I've seen it many times. One of the most recent ones I made was a lady, she had a humeral shaft fracture, had a radial nerve palsy for probably 5 months or so. And the doctor had her in just a wrist cock up, so a WHO. And I took her out of that and we put her in one. And the next time she came back, she talked about she was able to tie her shoes and just do little things that she couldn't do for 6 months. And it was just such a change in her life. And we got the pleasure to see her just kind of progress to where we cut it down to a hand-based, and then she, ended up getting full motion. And it wasn't that we did necessarily anything to provide that nerve return, but we put her in the proper positioning, prevented things that we didn't want to happen, and just gave her function. So I like to use that when there are many designs out there, a lot of big outriggers, and can be intimidating to make, but I find this one to be pretty simple and very effective.
That's great. Well, I mean, I love both ideas because a relative motion orthosis is not a simple one to make. And it depends on which finger you're targeting. It's a lot easier to target the middle and ring finger, but it's very tricky to position correctly for the little and index finger.
That's right. And I think that just creating, like understanding how to create the balance is the big key. I don't think people fully understand that always. They'll put the index finger in a relative flexion or extension, whichever they're trying to achieve, but they may not balance it in a way. And so the orthosis really just shifts and it doesn't create what we needed to create. So the patient wears it, but maybe they're not getting the full results that they need or any at all. So creating that balance has been huge. In the beginning, I probably didn't create it as much as I started to understand later. And I mean, it's been great. And once I figured it out, the patients love it too, because it's very minimal. So.
It is. And I also found with mine that I actually ended up using memory foam to exaggerate the relative position of the different fingers. And that kind of helped me to achieve what I wanted to achieve. So it's those little tips and tricks that you can share with us, which we often just
like I love the foam, and even just putting like a little trough to prevent so much, like with a trigger finger.
Yeah.
You can block the NP joint or you can go and block the PIP joint, but if you use a relative motion and just block a little bit of the final flexion and it's not triggering, they can function a little more and they're more likely to wear it. So I like doing little things like that, but you're right. The literature talks about in this diagnosis, it should maybe be 15 to 20 degrees relative.
Yeah.
Sagittal band, maybe 25 to 35. Well, with a chronic sagittal band, that's treated conservatively, I may go a little higher if it doesn't sublux, and I may shift them down later in treatment, but I'm not necessarily going exactly by that. If it doesn't work, then I'm not going to just not do it. I'm just going to increase my angle a little bit. And I may use something like foam or just kind of get creative to figure out how to get them in the position I need them to get and make sure they're not subluxing for that particular injury.
And really, it doesn't matter how long you've been a therapist. You could be certified for 25 years and you can always learn a new trick. So I think your lecture is really important.
Absolutely. That's what I love. I tell everybody at the courses, I always pick up one or two things from the group there that they do. And I love it because I get to learn more.
Yeah.
And I never go into a course, especially the orthosis courses, feeling like I don't want anybody to feel like I'm there to teach them and what I say is gold. I'm there to teach them what I know, but also to learn from them. It's an experience because they may do things differently than me. It doesn't mean that they're not getting results, but I may like something that they do better than I like, and vice versa. And it's just, all working together to make it, to make each of us better, but then also to progress our profession.
Same as me. In my mentoring club, I'm mentoring about 50 therapists, and we meet once a month, and I'm learning from them every day, and we're discovering new things. So you talk about nerve palsy and positioning. So we've discovered that with patients that have a claw deformity, the little and ring finger, with this one particular therapist has incidentally discovered that none of her anti-claw splints made any difference for months and months and months. But as soon as we positioned the patient in a cast, in a non-removable cast, using good old-fashioned plaster of Paris, it resolved the ulnar nerve palsy. And it hasn't come back when we've discontinued the cast. And it's actually been she's going to be presenting on it at the summit. And it is really fascinating, how we can actually heal those nerve palsies when we do the right thing.
Yeah, that'll be a great one to attend.
Yeah, you're going to love it. Contessa Stewart, you're going to love it. She's
Absolutely.
and it was quite funny because she messaged me and she said, I think I get this now. And I could see it. Being a mentor, you see things before your students do. So I could see she was onto a good thing because I've been doing this for so long. And then when she realized she was onto a good thing, it was just such a lovely revelation. And that's what's so nice about teaching and mentoring, is that we get to smile to ourselves and observe that beauty.
That's right. That aha moment. It's cool.
It is really cool. Well, and so just let us know how therapists can prepare for your session. Is there anything that they need to bring?
Well, if it's not a lot of material at all. If you want to follow along, typically you could take probably a quarter of a sheet and do everything. So just a strip, maybe 10 inches long, maybe a half an inch wide is all you would need for the relative motion. That's probably going to be too much, but I'd rather have a little more than not enough. And then I like to use the elastic thread and the stretch loop for my radial nerve palsy. And thread has been very hard to find, and loop in some places. So if you have like a Joann's or anything like that, like a store that has crafts, you could probably find the thread. I want to say it's like a 600 something count. So let's get that, and maybe we can post something about what we may need or what I'm going to use. I can post a link if that's possible.
Yes, actually, if you give me a PDF, then we can attach it to all the communications, and
Perfect. I'll put everything on there, and I'll put a link where to get it to, where I get it from.
Okay.
The hardest one to find, I think, is the thread. The elastic loop, most places sell that, or you can use something like pajama strap, but that's really all you need: some strapping and just an open mind.
Okay, awesome. Because I think this is a practical summit, and we're doing workshop-like lectures. So this will be wonderful if people know when your lecture is, have everything ready, bring a relative or friend, and they can actually try and work along with you. So I think that will be
Sounds great.
Great. Well, Bob, we are so honored to have you part of this summit.
The pleasure is all mine.
And I think that we are going to be wanting more and more after your lecture, I'm pretty sure. So thank you very much. And we look forward to seeing you very soon. It's not long now.
Absolutely. Yes, ma'am.
Thanks, Bob. Thanks for letting us know all about you.
Yes, ma'am.